Sure. Sorry, I got the pop-up. So yes, Bernie and Janet were very instrumental in getting launched. I mean, that was their baby, and we just were very fortunate to be able to partially fund it at first, and then we added on, doubled our funding the second year. But it's the CITE Community Intervention Team Enhanced at the City of Aurora Police Department, and they were collective. So take it away, Bernie and Janet.
All right, well, thank you so much for having us today, and thanks for Delilah for the opportunity for us to present on the program. I'm going to go ahead and share my screen if that is okay. All right, so hopefully you can see something that says Aurora Police Department up on the screen right now. So
I don't see it. I don't think so. Not yet.
No, you don't? Okay, let's try again.
There we go.
Okay. I apologize. Okay, so it was originally called our CITE team, Crisis Intervention Team Enhanced, and then it got kind of a re-kickoff about a year ago, or a little less than a year ago, and they decided to name it the Crisis Intervention Unit, and we'll talk a little bit about why that name change actually happened as I talk a little bit about the history of the program. So I wanted to also introduce my colleague, Jeanette Barba. She is our clinical director here at the agency, and she actually directly oversees our team at the Aurora Police Department. She's an Aurora native, so grew up there, so has a big investment in seeing the community be more responsive to the people in the community as well. So we'll be tag teaming a little bit on our presentation today. So we actually started in February of 2019, and I'm going to guess that most of you as members of 708 boards remember when they did some pretty deep cuts to the SAS program. So we were a SAS provider, we are a SAS provider, have been for many, many years. And when they did 67% rate cuts on our services in SAS, we had to find efficiencies and other ways to be able to deliver that program effectively. So we were kind of out on the street looking for space in other areas. So if you're familiar with Kane County, it's a long, kind of skinny county that's pretty densely populated. Our roads are fairly busy. So we are located on the way northern end of the county, yet a very significant amount of the people that we serve were in Aurora, which is on the southern end of the county. And it takes us a lot of time, right, to drive from one side of the county to the other. Additionally, reimbursement for travel and staff time to accomplish that, right? And so we were looking for office space that it would allow us to work more efficiently. The Aurora Police Department was very gracious in allowing us to actually co-locate with them. And they provided the space for free. So this was actually kind of the beginning of our relationship with them, because they were interested in partnering more with the SAS program specifically. So that would allow them to be able to have direct contact with crisis workers when particularly there were juveniles who needed interventions. And so there was, that was kind of the beginning of our partnership initially. Then they kind of recognized the potential for growth, right? They saw that, you know, SAS has some limitations, that it's very specific to youth, that it's Medicaid enrolled youth only, so that there were some things that were definitely limitations to them being able to utilize the service, and they were looking for more what they call social work services. I'm a social worker, Jeanette's a social worker, so we're both like, well, that's cool, we can go with social work, but you know, it's also a protected title, right? So really what we provide is mental health services, not specifically social work services with them. So in mid-2019, they talked about kind of expanding out into that. And then in December of 2019, we signed a formal memorandum of understanding with the city of Aurora to expand out the program. And in the initial process of rolling it out, it was initially funded by Dunham Foundation, which is a private foundation here in location. our agency, and then the King County Court Services. And then some of the Aurora aldermen actually kicked in funding to support the remainder portion of the program. And then Inc. Mental Health Alliance became a funder in July of 2020, which gave us much more stability in the funding of our programming after that initial kickoff happened. So in February of 2020 is when this program kicked off, and we all know what happened in this country in March of 2020, what happened in the world before March of 2020, but came to the United States shores in March of 2020 was the pandemic, right? And so, and then it wasn't long after that and the George Floyd incident happened. And so our beginning in this program was rather auspicious, to speak, but it took off very, very quickly. And I think you'll see that from the data that we have involved. And so really, what is our crisis intervention unit? It's us, Family Service Association and the Aurora Police Department partnering together. Today, we have 2 full-time police officers, 2 full-time social workers. They are partnered on morning and evening shifts. And then they have a actual commanding officer that's in charge. So there's a sergeant that's in charge of the unit, which is why we went from crisis intervention team enhanced to crisis intervention unit, because now it was actually a defined unit at the police department, which is important to them. So as a social worker, that doesn't necessarily make a whole lot of difference to me, but I guess how I would relate it is it's the same thing as in our agency, as if we define something as another program. So it gets a dedicated program manager that's paying attention to it. And that's kind of what ended up happening there, is that there was a sergeant who was actually paying closer attention to the daily operations of the program. So from there, I'm going to kick it over to Jeanette so she can talk more about the nitty-gritty details of what happens on a regular basis.
Great. Thanks, Bernie. As Bernie said, we have now two social workers, 2 officers, and they do work sometimes as a team, all 4 of them together, but mostly they're divided into morning shift and afternoon shift. So at Aurora Police Department, they have officers that are trained in a 40-hour class called Crisis Intervention Team, CITE, and our officers on our unit also have this training, but they have additional training and they work closely with the social workers. So what ends up happening is our program focuses more on your higher need cases and providing support as well to the regular patrol staff that are CIT trained. We do several different things. A lot of, like I said, things are in collaboration. We end up receiving reports that are mental health related from the officers. Those are considered like our referrals, but we also get referrals via email or just walk in because we are co-located. So it's not uncommon for officers to be able to walk in and say, hey, I have this situation going on, can you help me with this? We assess priority of reports. So some things are very high need and you have to take care of them that same day. And some things could maybe wait till the end of the week. And we do follow-ups, all of them in person. I'll explain a little bit more into that. Oh, I thought I could switch it. I can't. Okay, there you go. So talking about our social workers are unique in the sense that they speak both languages. They have both social work knowledge as well as like some law enforcement knowledge. So it helps them operate in both of the worlds together. Our full-timer that's in the morning, she is bilingual and she's paired with an English only speaking officer. And then in the evening, we have Bridget, who is only English speaking, but she's paired with a Spanish speaking officer. So our plan was to essentially ensure that during the shifts that we could cover, that there was a Spanish speaking ability, just because of the large Spanish speaking population in Aurora. Our social workers review the reports, which are the referrals, and we're looking at different risk components. We are seeing, was this an individual that was transported to the emergency room department because there were suicide risk? Those situations will require more of a prompt response versus a situation where police officers went and there was no major intervention, but there is a need for mental health services. So for those, we would reach out as well. there's multiple calls that come in to the office. The phone is ringing pretty often, and a lot of the times it's officers that have provided the office phone number, or clients that we've reached out and left a note for saying, hey, can you call us back? And sometimes we get the calls from dispatch themselves. If there's a situation that doesn't really require a response, but someone on the phone is in need of some support, then if our social workers are in the office, they're able to take those as well. Corresponse model. One of the buzz terms, keywords that gets used a lot now right now is co-response. So what does it mean, co-response, in I guess in how we mean it in our program, is that it's the pairing of a mental health professional and a law enforcement officer going and arriving at the scene at the same time. So it's a partnership. Each person has their own role that they have, but they also have mutual things that are kind of in common and in line. One thing that it really helps a lot is, as in Illinois, law enforcement officers do have like an 8-hour course that they're supposed to take. However, most of their calls have a lot of mental health related components in it, and having a social worker or mental health professional on site helps provide that professionalism, the knowledge of mental health concerns, provide additional guidance for officers there, as well as like teaching and training them on how to more appropriately respond to an individual in a mental health crisis. With co-response, we're also, because we have a mental health professional present, officers are more likely to be able to use even like their discretion on terms of, does this person really need to go to jail? Or is this something where we can assess and help link the client to treatment as opposed to jail? Especially when we are starting to gauge that the reason why they continue getting involved with police is more of an unaddressed mental health concern. And as in our area, and it's common everywhere else, that services are backed up. We have a lot of need for mental health services, and we kicked off right at the pandemic time, and we were busy and still continue to be busy. And I will foresee that we will stay busy because people are not able to access services right away. Oftentimes it results into a crisis. So with our program, because it responds as it occurs or as it happens, very much like a first responder situation, people are able to get services and access almost immediately. The other part though too is, because we have a social worker present, they can also provide guidance, as I said, about like how to manage a certain individual that might be presenting. So it's also safer for the individual and also the officers and the social workers. Implementation. So the co-response model we've already implemented. We are doing it now. We do also do co-response with the regular patrol officers as well. So we have our unit that goes out, but we also can send a social worker, one of our social workers, out with another officer. Again, same thing. It helps provide that professional that can do an assessment on scene, can help stabilize on scene, and provide that confidence though too, that the situation was managed, and there didn't need to be something more serious needing to be done. Like if a person really doesn't need to go to the hospital, we're actually decreasing people being transported to the emergency room that don't really need that, and decreasing people from going into jail that really don't need that. So the benefits, as I said, this is the intention of the program, and this is what we're seeing too, is the decrease in arrest and jail admissions. That is huge. There is a lot of individuals that Aurora sees on a repetitive basis. There's individuals that are struggling with very severe emotional disorders. Having this program involved allows the police department essentially to take more time in working with these individuals. So it's not like, oh, I saw you once and then that's it. We continue to follow up with them, and we use alternative, more time required interventions that usually families aren't able to do. So sometimes we will accompany the family to do a petition, but through the court, so the courts can actually have that mandated, and helping them with guardianship. So there's a lot of things that are done that will help with decreasing some of the arrests and the jail admissions. And it's like use of force as well, and psychiatric hospitalizations and repeat calls for service. So I do track recidivism, and for us, the recidivism is the individuals who are returning back through our program again, because our goal is that we have them linked out to services that they need and essentially do not have to rely on law enforcement as their main source of like mental health support. So from 2020, I have it broken down into quarters about the referrals that we received. So the first year, 2020, our goal was 500. We far exceeded 500, which we learned a lot in that first year with that having that influx. We knew the need was there. We just didn't realize how big of a need it was. So the numbers still increased by 2021, 851. So far, we're at 328. We do see it's gonna stay around that 700, 800 mark. I'm hoping the numbers will show that as the program is existing, we're having less recidivism, so we're also should be decreasing the amount of individuals that are being referred. But as the need grows, it's gonna kind of almost even out. This program is majorly focused on adults. So with SAS, we have the ability to work with children that have Medicaid or uninsured. A large population that is unserved is your adults that don't have insurance. And that makes up most of this adult population. Adults that we see don't have Medicaid, they don't have Medicare, they are in no treatment services at all. So it ends up becoming a huge challenge for them to even get access to services. And then population-wise, it's broken down. In 2021, we had pretty much across the board stayed about the same from 2021 to 2023 in terms of demographics is what we're noticing. I don't see those changing much, as well as if the female-male ratio. There's always going to be more males that we're seeing that are coming through our program. Although we did have a decrease in females. I guess that's something that I found interesting. So this recidivism, 2020, we kind of had our baseline, and then we looked at to 2021. We had 10% of individuals who came to us, essentially came to us, whether it was once, twice, or not 2 times, or 3 times, or more. And then in 2022, we were able to decrease it to 7%. So that's great for us, because we are essentially, if they're not coming back to us, it's because they're already linked into services or are no longer going into crisis. So, yeah. Oh, sorry. Collaborations. We have a lot of partners that we work with. So we are not, the goal of the program was not to replace any existing services. It was to provide a connection. Like we became the bridge to many of these, because a lot of the individuals that go into crisis, we can give them these phone numbers to different programs that they can go access services, but oftentimes they struggle at getting connections, getting through. So our partnerships with these different agencies, they're aware of our program, and we have like contact points with them where we can reach out to our contact point and say, hey, we have this individual that needs these services, can you help us out? So partnerships are huge and key in our program. We actually had a pretty interesting co-response situation. I think there's a video that's attached to that we can see. So the situation right here was that 911 dispatched our unit to the train station in Aurora because there was a youth, he's a young adult, that was essentially threatening suicide by cop. He had a knife, and he wanted to essentially get shot by the police officer. So it was just a really dangerous situation, because when we have a younger male with a knife, and we have officers that really weren't really sure how they best respond to that. So they called our unit, and our unit was able to respond. And in collaboration, one of our investigators talked to him, built a relationship with him, and was able to de-escalate the situation. We were able to get him transported to the hospital, where our social workers were able to do assessments and help link him out to hospitalization where he was needed to go. So this video is this one was just done recently. They wanted to highlight, the news wanted to highlight what our program was doing, and it also has the story of the individual that I just talked to you about, one of the examples of co-response and what that can look like.
Investigative reporter Chuck Gowdy here now with some early results of these new efforts and why the right response can be critical to public safety.
When someone is in a mental or behavioral health crisis, a call to 911 can become a crisis in itself. So what should happen when police, jail, and the use of force are not the best answers? Tonight, the I-Team with reimagined response teams aiming to redefine bad or even deadly outcomes.
I probably would have attacked someone just to have the officers be forced to shoot me.
Brian Solace was talked into living.
The call came out that it was a subject at the train station with the potential of being a suicide by cop situation. So we knew there was danger.
The tense scene captured on police dashcam video in June 2021 as the distraught teenager threatens suicide at the West Suburban Aurora train station. Among the responding officers, a newly formed crisis intervention unit with specially trained police investigators and social workers.
I was at that point where I was angry at everyone, everything, even at myself.
Solace opened up to the I-Team about the day he wanted to end his life at 18. An argument with a family member and his unmanaged mental illness sent him spiraling. He had a knife and was threatening to use it.
Just cracked and just was done with everything.
Those co-responders spending nearly an hour and a half talking with Solace until he gives up the knife. No one injured.
He's gotten help, and we were part of that process, and we would have never been, because it was not something that the police department had. It's something that we are doing now.
To deal with the increasing number of mental health crisis calls, police agencies across Illinois are adding social service programs to their departments. In the middle of a crisis or as a well-being follow-up, this Aurora unit works to identify individuals better served with intervention.
Kind of check and see how she's doing.
APD says so far this year, the unit has responded to nearly 100 more mental health calls compared to last year. Authorities say calls to 911 for non-emergencies have dropped.
We can see the recidivism go down almost immediately. We have a few of our regulars that instead of calling 911, they call us.
Back in Aurora, Brian Solace says he's a completely different person and doing well, but is uncertain of what would have happened without the reimagined intervention he received that day.
I'm very grateful for this. They talked me down. They saved me, essentially.
Authorities expect these programs to continue evolving, but both units we profiled tell us the programs will be limited with not enough follow-up mental health services or treatment facilities.
Thank you. They did such a great job at being able to put all that together. So yes, our unit still maintains contact with this youth. He's really gotten help, and he's doing a lot better, and he's in school as well. So it ended up having a really good storyline at the end. As they mentioned in the video, the only thing I didn't end up saying or going more into is our team does do follow-ups for everyone that is referred to us. And because we noticed year one, making phone calls is just not enough. So our team goes out every single day. In the morning, they already have the list of who we're going to go see. So the team goes and sees every person essentially in person versus just phone calls. That one.
Okay, do you want me to skip that one?
Yeah. Okay.
Okay, so just wanted to talk a little bit about what has worked for us and what hasn't necessarily worked for us. So like, what are those lessons learned so others hopefully don't have to redo our mistakes. So Being co-located and very visible. So we're also directly across from the training room in the Aurora Police Department, which means when they come in and they do their roll calls, they actually see us every day, which that visibility of like having those mental health professionals like kind of in your face, so to speak, is actually really helpful because it just reminds them that it's a resource that's available to them versus if we were like tucked away in a corner of the police department, I think it'd be easy in a department as large as Aurora's, which is, correct me if I'm wrong, JB, it's like 400 plus officers, I think. So like it'd be easy for them to be like, you know, like this is just not a thing that's available to them. So that was important. Our social workers also carry a radio so they can hear what's happening. So they can also kind of sort of interject themselves if they feel like there's a situation that would be helpful for them to be at, or if it's a name that comes across that they're already familiar with, that they also can then know that they need to be ready and prepared to also follow up. And they can take calls from people that they're actively working with or that are well known to the police department, so that can be an automatic deflection from police ever even being involved from the very first place. Our team does like what I call weekly rounds, where they actually have a meeting every week that includes the police officers, our social workers, and then other collaborators, where they'll go through the risk for the individuals that are involved in the program and determine what level of intervention that they need at that point. So if it's like Jeanette talked about, like, do we need an immediate response or do we need, you know, to respond like by the end of the week kind of thing? So it gives that time frame where they can tier out or triage the level of need for each individual. Sometimes in a co-response, the people are like surprised. They'll be like, hey, do you want to talk to a social worker? Because they're like kind of shut down when talking to the police. And then they'll be like, wait, you have a social worker with you? And it's just kind of surprising to people. And it's like automatically brings people down just a little bit. And so even them just feeling like it's a tool to intervene on occasions is really helpful in just kind of de-escalating situations, even if it's not the social worker that's up front in that particular circumstance. And we talked about having this dedicated unit of actually having a sergeant involved. So, you know, when we started, it was one social worker, one police officer. There was no dedicated sergeant. And then not having one person that's kind of paying attention to it. I think that might work at a smaller department, but one as large as Aurora, it just means the information didn't get up through the ranks very effectively. And so that also means, you know, police is a very top-down approach. For those of you who are not strongly involved with police departments, it's very militaristic in a way, right? And so if there's not buy-in from the top, it's not likely to be implemented very effectively. So it was harder to get that information through when we didn't have a dedicated unit or commanding officer available. Having the large support of an agency versus like an isolated social worker in a police department has been very helpful. So they have like the deep support of the organization. So if our social workers take time off or go on vacation, there's an alternate to that, right? There's people who can provide additional support. They have clinical supervision from Jeanette, and so that like that hand from the agency's policies and procedures all in place. The much deeper level of support that can come from an organization. As well as all of our programming, right, is sort of available to them in a very quick kind of way. Building those community partnerships that we talked about has been really key to our success. Going to roll call trainings for the police, because they have them at every shift change. So being there and being present, it's also been an opportunity for us to do additional trainings around particular areas like petition trainings, or trainings around how to best intervene, resources around if a person has autism, or things that are like maybe more unique circumstances that the police aren't quite as familiar with. Those have all been opportunities for us to share additional information. And then the exposure to other additional CIT officers beyond just our unit. So some police departments, like everybody has CIT training and they require it of all new officers. That's not the case in Aurora. It's those who are interested in doing it. But the amount of police that have been interested in doing it went up significantly when our team came into the department. So they almost doubled the number of people who were interested in doing CIT training after our social workers were available to them. People felt more confident in their ability to intervene and respond. So I talked about like having no commanding officer didn't work very well for us. I was a bit surprised to learn that billing Medicaid didn't work very well for us. We are a strong Medicaid billing agency, and how we have really supported our agency throughout the years. But it was not real effective in these co-response models because you don't have the opportunity to gather all the information that you might need to register somebody for services under, we have long registration processes that we have to submit to DHS to be able to then bill through HFS, right? And so those components were harder for us to gather that information, but we're also finding that the vast majority of people we're interacting with are uninsured entirely. And that makes some sense, right? Because they're having a harder time accessing other services in the community. So they end up going into crisis and then accessing through 911 versus through a mental health provider. Don't expect things to change very fast in policing environments. It's a slow change, and people had to get used to the idea of us being around, and it took time for officers to warm up to having somebody come along with them, and even to, think that it was okay to give us a call for follow-up. Like, that was a little hard for them to automatically trust that process as well. I think particularly being an external agency was hard for them to trust that process, but now they're very used to us being there, and it's the opposite. They don't know what they would do if we weren't there. So took a little time. Intern involvement has been rather hit and miss for us, and it's been a bit of a challenge integrating into that environment. And maybe that's again because of the slow change process, or because the job has intense moments and then down moments, and intense moments and down moments. And so it's a very fluctuating environment that's not very hard to schedule around, so to speak. Some of our barriers to implementation, buy-in from the city and police department initially was hard. Keeping in mind, again, we kicked off early 2020, prior to the death of George Floyd, prior to there being a lot of conversation about social work and police working together. And so initially there was some hard feelings about that, right? Of like, what are you doing here? And then I think then there was a very anti-policing sentiment that came out in the country. And then they also, were feeling vulnerable, I would say. Police were feeling vulnerable in many ways. And so there was some challenges in that. And I think when they came to trust that we're there to be as a team, it's been very strong since then, but there was some initial buy-in struggles with that. Again, sustainability of the program, because it's very hard to bill private insurances, Medicaid, Medicare, any of those. It's very hard to achieve. Aurora's a big city. 200,000 plus individuals live in the city of Aurora, and we have 2 full-time social workers that are managing that need. So a lot of need with minimal amounts of staff. And then some buy-in from the community around it, right? Because there's, again, some of the struggles around, like, is this your role as a social worker? Should you be doing this? Is there another way to go about it? We are also a 590-988 provider, also a SAS provider, right? So we're in a lot of those different types of crisis venues in our agency. So in our opinion, any layer and any effectively way that we can reach people is our best way to do it, right? And this is a way that we can reach people. People are reaching out to 911 for help. And so this has allowed us to intervene in a very immediate fashion. Some of our lessons learned, focusing on the integration of police social workers. So again, that office space, community events, like they're out there in community events, very visible. They have vests that they wear that say social worker on the back, and that's helpful. Like, they're very visible. They're in a uniform. It's a polo shirt, but in a uniform. police are big into uniforms and identification of people. So that has been something that we found that's also helped. Our staff collecting data so that we can focus on very specific areas to target and grow our program instead of like responding to everything that comes in, because there's too much that we would not be able to achieve with our 2 full-time staff. So this allows us to focus and intervene where we can be most effective, and then partner where that is going to be more effective. And then using a team approach for those very high risk situations where there's risk to our staff and risk to the person that we're serving. And so there's, we then we can dispatch all 4, right, to be present if that's what's going to be needed and be most helpful. Or they can work as a team where they can intervene in different shifts and be involved in that way too. And then providing education to the police and to the social workers, right? The social workers are also learning from the police, and it's that leveraging of both people's knowledge to make a very effective team that we're bringing all of those skills to the table when we're involved. And so this is how you can get a hold of both Jeanette and I, and we're open for any questions that you guys have. Yeah.
I have a question. Hi, I'm Leon, and thank you for your outstanding presentation. 2 social workers for a population of 200K, right? And I think you mentioned earlier something about, the struggle with, the interns, getting interns on board. So what are your steps, or what do you see as the next viable steps to hiring or recruiting more social workers for your team?
So yes, the need is definitely much greater than 2 social workers. I mean, even if we doubled it, this need is still going to be there, and the need's still going to grow. The program is, a toddler now. It's still little, but I feel like we've now demonstrated that this does work, right? And so now it's just about, like you said, just increasing the numbers. We have the foundation laid, and because we have the foundation laid and the data that we've collected, just earlier this month, the city of Aurora did get a presentation from our unit to be able to expand it. So we haven't heard back on the exact numbers, but the city of Aurora is essentially agreeing to be able to expand the program more, to add additional social workers and additional officers. So for every officer we get, we're going to get a social worker, because they work in partnerships, which will also allow us to be able to cover more shifts, because right now we have morning and day. Weekend is still a challenge. So yeah, so there's plenty of people want to do police social work. So I feel like it's a hot job for people to want to apply to. Yeah, so I think people are interested. Not everyone can do this type of job, right? But yeah, so funding right now is really the bigger strain.
Although it's huge that the city of Aurora has stepped in and said, we're willing to put money on the table, because this is the first time they have done that. It has been fully funded through community partnerships and not through them. So that shows some good buy-in to like, hey, we're here, we're ready to be. We did get a new chief in the process too, chief of police. And the new chief of police is very bought in, believes this is a really solid program. Chief Cross grew up, I should say, he literally did grow up in Aurora, but like grew up in the Aurora Police Force, and it really believes this is an important component of theirs. So that's good. And so I think that he's naturally going to look to sort of expand the program.
They don't want to lose it, that's for sure. Like now they're already like invested in terms of officers utilize us, extensively. It's now being a unit, it's really integrated now. And that I would say is just huge though, too, to be integrated, already accepted, as part of them.
Thank you.
I have a question, kind of a 2-parter. Thank you for this presentation. It was really great. You talked a lot about the importance of building trust and sort of how you did that, but I really want to focus a spotlight on that. Like it's so important to the success of the program. So building trust between the social workers and law enforcement. And like how, you know, you talked about being able to sort of interject yourselves when you think there might be an occasion where social workers may have a role to play. Like that requires trust for law enforcement to listen to you guys and say, oh yeah, you guys might be right, versus think, you know, no, I've got this covered. So like, so the first part of my question really is, how do you do that day to day? How do you do that? And the other part of the question I think is related is, how do you do that while also maintaining your own culture? And there's a lot of research out there about, you know, when you sort of, when you put your physical bodies into, you know, a sort like you described as militaristic, right? Like I've read a lot of research about people who work, social workers or other clinicians who work in prison settings, and how it changes you. It just has to. And so how do you gird yourselves against that or prevent that so that you keep your focus and your outlook while also partnering? Sorry, that was long, I know.
Yeah, that's okay. No, that was huge. That was really important to us on like, how do we get that buy-in, right? From, you know, if a supervisor says, let's do it, you know, that's one part, but the officers really wanting to utilize us, to trust us to go out with them, to ride with them. So the approach that I went with is that I wanted it to be a natural process, as natural as it could be. I made it clear that I didn't want any officer being forced to ride with any of our workers. And a lot of it also was presence. So we were present in the police department. That helped. Getting a uniformed shirt, they like, you know, things, they were able to identify us. Now we weren't just like a random person in the building, like, oh, we had a certain identification now. That helped. We were present at like police officer either trainings that were related even to mental health. We put on some additional trainings. Our door was always open, and since they would do in-service during the different shifts, it was not uncommon for them to come and like talk to us, but we also would join them, even just to sit down and listen to what's going on. So a lot of it, the focus was being as organic as possible. And it did work out that way. So initially it started with, you know, smaller level calls, and then the officers, you know, would watch, see what kind of happened, and it wouldn't take long for them to be like, oh, like cool, like you know, this actually is working, or this is helpful. And they even started then adapting some of the things that we were doing. So they would start saying, you know, asking or saying similar things that we were saying then to other individuals. So buy-in was very organic. We had officers, no one ever was forced to take anyone. And it was actually the opposite. Officers would be like, hey, why don't you guys ride with us? Like, why don't you ride with me? And that's how it essentially it went. And then how do we keep the culture? I think what helps is that our social workers are still connected to an agency, right? So they still, a lot of their work is going to be still clinical focus. We're still doing trainings with them. We still do clinical supervision. We still view things through like a clinical mental health professional lens. But yes, no, it is definitely a challenge because it's a different culture. And I think that's important too, is that the people for the job have to be the right type of people who can respect their culture, but also be able to stand up for, like, as a mental health professional, say, hey, this is appropriate, or hey, this is not appropriate. So you need an individual that can do both, be respectful, but also ask for respect if needed.
Let's throw a couple more things in there. Speak their lingo, right? I think that was helpful, us learning and being able to like take a radio, and which is honestly intimidating to our staff, because they're now on a radio where there's 100 police officers listening in on this, and like if they say the wrong thing, things can go wrong, right? So it's a little intimidating to them. So there was a lot of us having to learn their policies and procedures, their environment initially, right? And then that gave us the trust to push back in the spots that we felt were critical for us to do so. And so it's a lot of that give and take, I would say, on the front end.
Yeah, making it as collaborative as possible, you know, even in the decisions that we make, you know, out in the field together. really focusing on our own safety. So we're not posing a safety risk now to the client, or, you know, now the officer has to be worried about it. So a lot of it is really too on the people that you're hiring, you know, that it's a good person that can take on all those additional tasks.
Thank you.
We have a question.
Yeah, I just had a quick question. So like the social workers, what kind of training do they have to do? Or is there like additional training, or is it kind of more like on the job? Because like police social work is like pretty new, and like I feel like there's a lot of different like you said, tasks and stuff involved, or like you said, like safety. So I was just wondering like where you learned that, I guess.
Yeah, so we had to develop it uniquely for our population that we're serving in the area that we're serving with the police department that we're working with, right? So it had to be very custom. We didn't have like this is the police social work model that we're going to work off of. What we did is pull things that we knew worked already in the field and then adapted them for this. So a huge component was that our staff get trained in crisis intervention, that they know how to assess for risk. They know how to, you know, safety plan if needed. They know how to de-escalate, and they know about different services that they can connect families to. So having those crisis intervention based skills is the foundation. The other on top of that is case management. How they know about like, the different service areas, what they need to go in, like what's required to be accepted into those places, but also someone that has the skill to be able to talk to families to help motivate or engage them into getting connected to services. The additional training to that is the social workers did get some on the police side, some training that had to do more with like for them to be aware of like what is use of force and what does that look like, or things related to safety. Like if something happens, what do we do? And the reality is we run. You know, we don't stay there. Our vests are really just there for us to get out of the way. And ongoing training. So since I still meet with them for clinical supervision, we focus on what we see as being like maybe a bigger issue that we have presenting. Like we've done a lot of focus on psychosis, you know, individuals who are really struggling with schizophrenia. So we've done different trainings like that, trainings on petitions, the law essentially related to mental health. So yeah, variety of mental health related stuff and then legal stuff together.
Have you found there to be any maybe positive or negative unanticipated results of the program as it relates to your people navigating the court system, and either police being able to show up for court dates and having additional information that maybe in the past hasn't been available to judges, connecting people with services for those coming out of incarceration, or even per a judge recommendation for a court hearing, anything to that effect?
See, what was a surprise to me was I would say the interventions that were more time intensive, like going with families to court to fill out like guardianship paperwork, or to fill out a petition, you know, in front of a judge to get it then approved. So I would say the interventions that were not typical for a law enforcement police officer to do, that those got taken on by our unit kind of organically. Like we saw the need, like we have an individual, for example, that does not right now immediately need to be like doesn't meet criteria for immediate hospitalization, but they're just right under the cusp though, and they have like a long history of just struggling, and we're able to then present those cases, you know, to the judge and identify these are the concerns that we have and work with the family too in partnership with them. So I would say that was we've done several of those, which has helped essentially keep people also from the revolving door of the same hospital, because we can have a judge say, hey, can you have them do an evaluation at, you know, Edwards, or, you know, wherever it might be too. And it provides additional support to be able to get the individual to the care going that way. I would say guardianship, that's one thing that I didn't really expect that we were going to be doing a lot on, but we have a lot of adults who their families are taking care of them and they don't have guardianship, so they aren't able to like help their adult, family member with mental health resources. I would say those were probably the bigger two that I just didn't anticipate us getting as involved with court, I guess, in that process.
Okay, any final questions for our guests? All right. Well, thank you so much for presenting to us today. This was really a great presentation, very thoughtful discussion, and it sounds like you're, really far along compared to where a lot of other communities are, even though it's kind of new in general. And so it's encouraging to see where you're at after 3 years and hope that some of our newer programs can get to that level. Delilah, again, thank you for setting that up for us today. And we can adjourn this meeting, and we will be meeting again in a month, at which point we do not have a presentation scheduled. So that will probably be more of a touching base on CESA and other things, and then hopefully have one set up for the following month. Thanks, everyone.
Thank you. Thanks, everyone. Bye-bye.